Hello, good day everybody. It's me again, but this time I'm going to talk about the Medicamentosa dermatitis and food allergy. So as usual, we're going to talk about its definition, its etiology and pathophysiology, its clinical manifestation, the diagnostic procedures, its nursing management, its nursing diagnosis, and prognosis. So I hope you keep watching and listening to my video. Good day, everybody. So today, first I'm going to discuss what is medicamentosa dermatitis, or AKA the drug eruption or the drug reaction. I'm going to discuss its description or definition, etiology and pathophysiology, the clinical manifestations, the diagnostic procedures, treatment or medical management, nursing diagnosis, and prognosis. So, dermatitis medicamentosa or drug eruption is an eruption of the skin or mucous membranes that can occur within 1 hour and up to 2 weeks after drug administration. These eruptions imitate almost all of the morphologic variations in dermatology, including exanthems, urticaria, photosensitivity, fixed drug reactions, palpable purpura, bullae, alopecia, onycholysis, acral erythema, chenoid, acneiform lesions, lupus erythematosus-like lesions, toxic epidermal necrolysis, and erythema multiforme syndrome. Maculopapular exanthema is the skin eruption that is most commonly induced by a wide range of drugs. Any eruption caused by the injection, or inhalation of a drug, most often the result of allergic sensitization, reactions to drugs applied to the cutaneous surface, are not generally designated as a drug eruption, but as contact-type dermatitis. Drug eruptions can mimic a wide range of dermatoses. They may be related to traditional pharmaceutical agents, biologic agents, and targeted immunotherapeutic agents, food additives, and dyes. The morphologies are myriad and include morbilliform, urticarial, papulosquamous pustular, and bullous. Medications can also cause pruritus and dyspepsia without an obvious eruption. A drug-induced reaction should be considered in any patient who is taking medications and who suddenly develops a symmetric cutaneous eruption. Morbilliform eruption localized to stray has been described with clindamycin. In etiology, fibrosing reactions have been associated with a variety of chemical exposures. Nephrogenic systemic fibrosis has been associated with gadolinium contrast agents used for MRI studies. Individuals with renal failure may have a buildup gadolinium in the skin and other organs and may recruit CD34 positive bone marrow derived fibrocytes into lesional areas. Toxic oil ingestions has been associated with morphia, and texture disease has been associated with phytomenageon or vitamin K1 injections. Rates of reactions to commonly used drugs are as follows. Number 1 is amoxicillin, which is 5.1%, the trimethoprim sulfamethoxazole, ampicillin, semisynthetic penicillin, blood penicillin, cephalosporins, quinidine, gentamicin sulfate, PAC-RBCs, mercurial diuretics, and heparin. Drugs that commonly cause serious reactions are as follows. Number 1 is allopurinol, anticonvulsants, NSAIDs, sulfodrugs, bumetanide, captopril, furosemide, penicillamine, piroxicam, thiazide diuretics. Drugs associated with specific morphologic patterns are described below. The following is a list of medications that have been reported to cause specific types of cutaneous reactions. However, not every possible type of drug eruption has been listed. In addition, exclusion of a drug from the following list does not imply that it is not a cause of a patient's eruption. A high index of suspicion must always be maintained when confronted with a new onset eruption in a patient on multiple medications. Note the following. Number 1 is acneiform, which includes amoxapine, corticosteroids, halogens, haloperidol, hormones, isoniazid, lithium, phenytoin, and trazodone. And in pathophysiology, drug eruptions or the Medicamentosa dermatitis may be divided into two parts, which is immunologically and non-immunologically mediated reactions. So for the immunologically mediated reactions, there are four types, which is type 1, type 2, type 3, and type 4. So in type 1, it leads to immunoglobulin E or IgE dependent reactions, which results in urticaria, angioedema, and anaphylaxis. In type 2, it leads to cytotoxic reactions, which results in hemolysis and purpura. In type 3, immune complex reactions, which results in vasculitis, serum, sickness, and urticaria. In type 4, it leads to delayed type reactions with cell-mediated hypersensitivity, which results in contact dermatitis, exanthematose reactions, and photoallergic reactions. So all of this leads to Th17 T cells, which it is implicated in many drug eruptions, and sulfamethoxazole induces T cell switch mechanism based on the TCRV beta 21, which domains of altering peptide HLA recognition. In severe drug reactions, microRNA 18A 5P down regulates the expression of the anti-apoptotic B-cell lymphoma, leukemia 2 like protein 10 promoting apoptosis, which it leads to insulin and other proteins are associated with type 1 reactions. Penicillin, cephalosporin, sulfonamides, and rifampin are known to cause type 2 reactions. The quinine, salicylates, chlorpromazine, and sulfonamides can cause type 3 reactions. The type 4 reactions, the most common mechanism of drug eruptions, are often encountered in cases of contact hypersensitivity to topical medications such as neomycin. Sulfonamides are most frequently associated with toxic epidermal necrolysis or TEN. And lastly, it leads to although most drug eruptions are type 4 hypersensitivity reactions, only a minority are IgE dependent. That is, antibodies can demonstrate it in less than 5% of the cutaneous drug reactions. Type 4 cell-mediated reactions are not dose dependent. They usually begin 7 to 20 days after the medication is started. They may involve blood or tissue eosinophilia, and they may recur if drugs chemically related to the causative agent are administered. So in non-immunologically mediated reactions, it is divided into 8 types, which is first accumulation, and it leads to argyria, which is blue-gray discoloration of the blue skin and nails, and it is observed with use of silver nitrate and nasal sprays. And the adverse effects, it leads to normal but unwanted effects of a drug. For example, anti-metabolite chemotherapeutic agents such as the cyclophosphamide are associated with hair loss. The direct release of mast cell mediators is a dose-dependent phenomenon that does not involve antibodies. For example, aspirin and other NSAID cause a shift in leukotriene production, which triggers the release of a histamine and other mast cell mediators. The idiosyncratic reactions, it is unpredictable and not explained by the pharmacologic properties of the drug. An example is the individual with infectious mononucleosis who develops a rash when given ampicillin. In intolerance, occur in patients with altered metabolism. For example, The individuals who are slow acetylators of the enzyme N. The acetyltransferase are more likely than others to develop drug-induced lupus in response to procainamide, a Jarich-Herxheimer phenomenon. It leads to the reaction, which is due to bacterial endotoxins and microbial antigens that are liberated by the destruction of the microorganisms. The reaction is not an indication to stop treatment because symptoms resolve with continued therapy. In overdosage, it leads to exaggerated response to an increased amount of a medication. For example, increased doses of anticoagulants may result in purpura. In phototoxic dermatitis, it results to or leads to an exaggerated sunburn response caused by the formation of the toxic photoproducts such as free radicals or reactive oxygen species. In clinical manifestations of medicamentosa dermatitis, although most drug eruptions are exanthematous, different types of drug eruptions are described. With every drug eruption, it is important to evaluate for certain clinical features that may indicate a severe, potentially life-threatening drug reaction such as TEN or TEN or hypersensitivity syndrome. Such features includes the following: mucous membrane erosions, blisters, Nikolsky sign, which is an epidermis slot with lateral pressure and indicates serious eruption that may constitute a medical emergency. Confluent erythema, angioedema and tongue swelling, and palpable purpura and skin necrosis. So here is an example picture of a condition which is the skin necrosis and lymphadenopathy, high fever, dyspnea, or hypotension. Patients may come in for an office visit with variety of skin reactions such as itching, burning, pain, or without rashes. So the most common is a confluent maculopapular rash that may be pruritic. Knowledge about onset, progressions of symptoms, fever, recent medication change, and family history of essential. Onset can occur 7 to 10 days after the drug is started, but may not occur until the course of medication is finished. The rash can last to 1 to 2 weeks and then fade. The rash may also be urticarial or always highly suggestive of drug reaction, or fixed drug reaction that occurs in the same area each time the drug is taken. So here's a table for the clinical manifestation of the medicamentosa dermatitis. So in diagnostic procedures, how are drug eruptions diagnosed? So via careful history, skin and general physical examination are necessary to diagnose a drug eruption and to assess its severity. To determine any previous exposure to the medications under suspicion, review the medical record to determine the relationship between onset of symptoms and commencing medications. Some medications such as antibiotics and anti-epileptic drugs are more likely than others, such as cardiac medications, to cause drug eruptions. Medications may need to be stopped and later introduced to see whether symptoms recur. In laboratory studies, history and physical examinations are often sufficient for diagnosing mild asymptomatic eruptions. Severe or persistent eruptions may require further diagnostic testing. Much research is directed at identifying laboratory techniques that can establish a diagnosis of a drug eruption. In current practice, most of these techniques are still too early in development for routine clinical use. Diagnostic tools for the assessment of allergic rashes usually still depend on challenges to identify the causative agents. Biopsy can be helpful in confirming the diagnosis of a drug reaction. Example of the given by showing eosinophils and morbilliform eruptions or numerous neutrophils without vasculitis in persons with sweet syndrome. Drug eruptions are associated with a wide range of histologic findings and immunomodulating medication can alter the histologic picture. CBC count with differential may show leukopenia, thrombocytopenia, and eosinophilia in patients with serious drug eruptions. Serum chemistry studies may be useful. Liver involvement leading to death can occur in persons with hypersensitivity syndrome. Special attention should be paid to the electrolyte balance and renal and hepatic function indices in patients with severe reactions such as SGS, PEN, or vasculitis. Antibody or immunoserology tests may be ordered. Antihistone antibodies are noted in persons with drug-induced SLE, whereas anti-ROSSA antibodies are most common in persons with drug-induced SCLE. Direct cultures may be needed to investigate the primary infectious etiology or secondary infection. Urinalysis, stool GAC tests, and chest radiography are important for patients with vasculitis. In imaging studies, chest radiography along with urinalysis and stool tests is important for patients with vasculitis. In other tests, rechallenge tests by means of skin prick or patch testing to confirm the causative agent is of limited value. Skin tests may be hazardous to patients who have severe reactions, with the possible exception of acute generalized exanthematous pustulosis or AGEP or AGAP. Patch tests have a low sensitivity and specificity and are not useful. In histologic findings, in some cases, biopsy may be helpful in establishing a diagnosis of a drug reaction. Histopathology of an exanthematous drug reaction may show both superficial and deep perivascular inflammatory cell infiltrates. Eosinophils in the infiltrate suggest such a drug eruption. So here's a photo of a superficial perivascular inflammatory infiltrate with numerous eosinophils, which are characteristic of an exanthematous drug eruption. Treatment or medical management of medicamentosa dermatitis. The first ultimate goal is always to discontinue the offending medication if possible. Individuals with drug eruptions are often the most ill patients taking the most medications, many of which are essential for their survival. However, all non-essential medications should be limited. Once the offending drug has been identified, it should be promptly discontinued. Knowledge of the common eruption inducing medications may help in identifying the offending drug. Patients can possibly continue to be treated through morbilliform eruptions. The eruptions often resolves, especially if the individual is being treated with antihistamines. So most authorities believe that exanthematous drug eruptions are not a precursor to severe reactions such as TEN. Nevertheless, all patients with severe morbilliform eruptions should be monitored for mucous membrane lesions, blistering, and skin sloughing. Treatment of a drug eruption depends on the specific type of reaction. Therapy for exanthematous drug eruption is supportive in nature. First-generation antihistamines are used 24 hours per day, and mild topical steroids, example of the given is hydrocortisone and disonoid, and moisturizing lotions are also used, especially during the late desquamative phase. Severe reactions such as SGS, TAN, and hypersensitivity reactions and warrant hospital admissions. TEN or TN is best managed in burn unit with special attention given to electrolyte balance and signs of secondary infection. Because adhesions can develop and result in blindness, evaluation by an ophthalmologist is mandatory. In addition, mounting evidence indicates that intravenous immunoglobulin may improve outcomes for TAN patients. The therapy for most drug eruptions is mainly supportive in nature. Morbilliform eruptions are treated with oral antihistamines and topical steroids. IVIG is currently the most common agent used to treat TEN. Cyclosporine may also have a role in treatment of TEN. Prednisone may be used in the treatment of hypersensitivity syndrome with heart and lung involvement, severe serum sickness like reactionist wheat syndrome. Topical corticosteroids such as the betamethasone cream are safe in the short term and may reduce symptoms. The emollients can be applied liberally and frequently. The drug-induced urticaria often responds to antihistamines, but they are rarely useful for other eruptions. So, a small note that we need to educate the patient to avoid re-exposure to the responsible medication and known drugs with it cross-reacts. Nursing management, if the responsible drug is already identified, advise the patient to avoid that drug in the future. Clearly label the medical record, advise the patient to carry a card or some other form of emergency identification in their wallets that lists the drug allergies or intolerances, especially if they have had a severe reaction. Advise patients about drugs that are cross-reactive and about drugs that must be avoided. For example, penicillin allergy reactions have cross-reactivity with cephalosporins, phenytoin hypersensitivity syndrome has a cross-reactivity with phenobarbital and carbamazepine, and sulfonamide reactions cross-react with other sulfa-containing drugs. Assess the patient's knowledge. The nurse must also assess the patient's understanding of previous reactions and steps taken by the patient and the family to prevent further exposure to the antigens. So the nursing diagnosis for the Dermatitis medicamentosa, first, impaired skin integrity related to contact with irritants or allergens. Number 2 is disturbed body image related to visible skin lesions. Number 3, risk for infection related to severe inflammation and excoriation. Its prognosis. So most drug eruptions are mild, self-limited, and usually resolve after the offending agent has been discontinued. Even after the responsible agent is discontinued, drug eruptions or the medicamentosa dermatitis may clearly, slowly, or worsen over the next few days. The degree of eosinophilia is predictive of the severity of the drug eruption. The time required for a total clearing may be 1 to 2 weeks or longer. Severe and potentially life-threatening eruptions occurs in approximately 1 in 1,000 hospital patients. Mortality rates for erythema multiforme or EM major are significantly higher. The Stevens-Johnson syndrome or the SJS has a mortality rate of less than 5%, whereas the rate for TN approaches 20 to 30%. Most patients die from sepsis. Patients with exanthematous eruption should have counseled to expect mild desquamation as the rash resolves. Patients with hypersensitivity syndrome are at risk of becoming hypothyroid, usually within the first 4 to 12 weeks after the reaction. The prognosis for patients with TN is guarded. Scarring, blindness, and death are possible. So that is all about for the medicamentosa dermatitis. So now we're going to tackle about the food allergies. So I'm going to discuss about the food allergy. Food allergy is an immune system reaction that occurs soon after a certain food. Even a tiny amount of allergy-causing food can trigger signs and symptoms such as digestive problems, hives, or swollen airways. In some people, a food allergy can cause severe symptoms or even a life-threatening reaction known as anaphylaxis. Food allergy affects an estimated 6 to 8% of children under age 3 and up to 3% of adults. While there's no cure, some children outgrow their food allergy as they get older. It's easy to confuse a food allergy with a much more common reaction known as food intolerance. While bothersome, food intolerance is a less serious condition that does not involve the immune system. Food allergies are immunologically mediated adverse reaction to foods. Any food protein can trigger an allergic response, and allergic reactions to a large number of foods have been documented. However, only a small group of foods account for most of these reactions. Eggs, milk, peanuts, soy, fish, shellfish, tree nuts, and wheat are the foods most often implicated. In etiology, food allergies are primarily the result of immune responses to food proteins. allergic reactions to non-protein food additives are uncommon. Normally, non-inflammatory immune responses develop to ingested foods in a process called oral tolerance, for reasons that remain unclear, but likely include environmental and genetic factors. Tolerance may be abrogated, leading to adverse immune responses. While sensitization to an allergen has been primarily assumed to occur from ingestion, this may not always be the case. For example, oral allergy syndrome or pollen food related syndrome, it describes an allergic response to specific raw fruits or vegetables that share homologous proteins with pollens. The initial route of sensitization is respiratory exposure to pollen proteins rather than oral exposure to food proteins. The skin may be another potential route of sensitization. So the common food allergic triggers, it accounts for about 90% of all food allergies, and people commonly refer to them as the big 8 allergens. So these foods are eggs, fish, milk, nuts from trees, peanuts, shellfish, soybeans, and wheat. So the pathophysiology or the pathogenesis for the food allergy, it leads to its etiology. Most common allergenic foods account for about 90% of food allergies, and people commonly refer to them as the big 8 allergens. So these foods are eggs, soybeans, fish, wheat, milk, shellfish, including shrimps, lobsters, and crabs, nuts such as hazelnuts, walnuts, cashews, pistachios, and peanuts. So first, it leads to immune response to gluten proteins in grain, and after that, it leads to celiac disease. So this celiac disease is an immune disease which people can't eat gluten because it will damage their small intestine. And we're going back to the etiology. Then after that, it leads to IgE-mediated gastrointestinal food allergy, which the onset is approximately 30 to 60 minutes after food ingestion. Then it leads to immediate hypersensitivity reactions and pollen food allergy syndrome or the oral allergy syndrome. So these two, it leads to one of the symptoms for the food allergy is nausea, vomiting, abdominal pain, and cramping. So going back to the etiology, then leads to the mixed IgE or non-IgE gastrointestinal food allergy or the eosinophilic esophagitis and gastroenteritis. Then leads to the, and symptoms may vary according to the location of the eosinophilia. Then eosinophilic esophagitis appears to be a chronic disease, and fibrosis and stricture formation could occur. And it leads to postprandial nausea and abdominal pain, sensation of early satiety. The non-IgE mediated gastrointestinal food allergy, its onset is several hours to days after the food ingestion. So it leads to food-induced pulmonary hemosiderosis or the Henner syndrome, which is also called cow's milk hypersensitivity. It is a food-induced pulmonary hypersensitizing syndrome that affects primarily infants and that is characterized by pulmonary hemosiderosis, digestive bleeding, anemia, and poor growing, improving with elimination of cow's milk from the diet. The non-IgE mediated gastrointestinal food allergy also leads to food protein-induced enterocolitis syndrome or the FPIES, typically manifest in the first few months of life with severe projectile vomiting, diarrhea, and failure to thrive. And after that, it leads to cow milk and soy protein formulas that are usually responsible for these reactions. However, solid foods may also trigger these reactions, especially rice and oats. And after that, it leads to the allergen is removed from the diet. Symptoms resolve. Pre-exposure prior to resolution results in a delayed of 2 hours onset of vomiting, lethargy, increasing in the peripheral blood, polymorphonuclear leukocyte count, later diarrhea. Hypotension and methylglobinemia may occur. In clinical manifestations, most food-related symptoms occur within 2 hours of ingestion. Often they start within minutes. In some very rare cases, the reaction may be delayed by 4 to 6 hours or even longer. Delayed reactions are most typically seen in children who develop eczema as a symptoms of food allergy and in people with a rare allergy to red meat caused by the bite of a Lone Star tick. So in food allergy, who is at risk? Anyone can experience food allergy, but some risk factors make it more likely to develop. Family history. Food allergies can run in families. If close family members have asthma or any allergic diseases, including food allergies, eczema, and seasonal allergies, the person is more likely to develop food allergies. In other allergic conditions, a child with one allergic condition often develops others too. These conditions include food allergies, asthma, and seasonal allergies. In early experiences, research has shown that babies born by cesarean delivery may be more likely to develop food allergies. Introducing common allergens such as peanuts earlier in life can reduce the risk of food allergies developing. In gut bacteria, some research shows that people with nut or seasonal allergies have altered gut bacteria. Specifically, they have higher levels of bacteroideals and lower levels of clostridial strains. Scientists are trying to determine whether influencing gut bacteria could help treat or prevent allergies. In diagnostic procedures, to diagnose an allergy, the doctor will ask the person about their reactions to the food. They will want to know what symptoms occur, how long it takes for the reaction to begin, which food caused it, whether the food is cooked, where the person eats it. The doctor will also be interested in any other existing allergies such as the seasonal allergies or asthma and the person's family history of allergies. The following tests can help the doctor diagnose a food allergy. Number 1 is skin prick test. A healthcare professional places diluted foods onto the person's arm and lightly pierces the skin. In any reaction, such as itching, swelling, or redness indicates that the person may have an allergy. People may need to repeat this test several times. Blood test. This test looks for the presence of antibodies that are specific to certain food proteins and can indicate an allergy. The food diary. The person writes down everything that they eat and describes symptoms if they occur. Next is the physician-supervised blinded oral food challenge. This is the most scientific method to diagnose a food allergy accurately. A physician gives the person a suspected food allergen in increasing amounts, monitoring for symptoms under close supervision. This method removes the chance of psychological reactions. The physical examination findings are most useful for assessing overall nutritional status, growth parameters, and signs of other allergic diseases, such as atopic dermatitis, allergic rhinitis, or asthma. Findings from a comprehensive physical examination can help rule out other conditions that may mimic food allergy. Recognize the early signs and symptoms of an allergic reaction. Keep in mind that cutaneous, gastrointestinal, and respiratory symptoms are the most common clinical manifestation of food allergy. Conditions to consider in the differential diagnosis of food allergies include the following: the auriculotemporal syndrome, esophagitis, factitious disorder, food poisoning, acute gastritis, and chronic gastritis. The approach to the diagnosis of food allergy requires consideration of the history, the epidemiology of food allergic disease, cross-reactivity, and the degree of positivity of tests. This must be evaluated to assist in diagnosis. Simple tests for food-specific IgE antibodies are available, but the clinic must appreciate that a positive test for food-specific IgE primarily denotes sensitization and may not confirm clinical allergy. Physician-supervised oral food challenge may be required for diagnosis. In treatment or medical management, the traditional way to manage food allergies has been to avoid the food that causes the reaction. People can also treat the symptoms of reaction when they arise. Oral immunotherapy is a relatively new and investigative way to manage food allergies. It involves giving the person increasing amounts of an allergen to increase the threshold that triggers a reaction. Oral immunotherapy is not available for all foods, but the Food and Drug Administration or FDA have approved a treatment for peanut allergy called Palforzia. Elimination may involve not only not eating the particular food but also never inhaling it, touching it, or eating foods with traces of it inside. Cutlery, crockery, cooking surfaces, and chopping boards may also need to be free of the allergen. When on an elimination diet, a person may need to look for other sources of certain nutrients. For instance, milk is a common source of calcium and protein. So people removing this from their diet will need to ensure that they get these nutrients from other foods. People will also need to read food and drink labels carefully. Even some soaps, pet foods, glues, and adhesives may have traces of a food allergen. When eating out, being vigilant can be particularly difficult. So for medication for emergencies, the following medication are helpful in the event of an allergic reaction. Antihistamines. These come in the form of gels, liquids, or tablets. They are usually effective for people with mild or moderate food allergy symptoms. Histamines are chemicals that cause most allergy symptoms, and antihistamines block their effects. Epinephrine or adrenaline. This treatment is for individuals who have food allergies that may result in anaphylaxis. Epinephrine keeps blood pressure up by constricting the blood vessels. It also relaxes the airways, and people who have had severe allergic reaction should always carry an epinephrine auto-injector such as an EpiPen, Junior, Quinject, or Auvi-Q. So the nursing managements for food allergy, it includes assess the client for the sensation of a narrowed airway, monitor oxygen saturation and arterial blood gases or ABG, assess the client's knowledge of the condition and exposure to allergens, encourage adequate rest, and limit activities to within client's tolerance. So the nursing diagnosis for food allergy, an ineffective breathing pattern related to facial angioedema as evidenced by dyspnea and wheezing, impaired gas exchange related to ventilation, perfusion imbalance as evidenced by dyspnea and tachycardia, and deficient knowledge related to lack of recall as evidenced by inability to identify allergens and recurrent allergic reactions. In the prognosis of food allergy, in general, most infants and young children outgrow or become clinically tolerant of their food hypersensitivities. Specifically, most outgrow allergies to milk, egg, soy, and wheat. Allergies to peanut, tree nuts, fish, or shellfish are most persistent. Population-based studies generally show that 85% of young children outgrow their allergy to milk or egg by age 3 to 5 years old. However, studies reported from a referral center showed more persistence of egg, milk, and soy allergies, with only about 50% of patients resolving these allergies by age 8 to 12 years. Children continue to lose their allergy into the adolescent years. About 20% of infants and young children experience resolution of their peanut allergy by the time they reach school age. Children with non-IgE mediated food allergies such as proctocolitis and enterocolitis typically resolve their food allergy in the first years of life. Allergic eosinophilic esophagitis appears to be a persistent disorder. In morbidity and mortality, severe anaphylactic reaction, including death, can occur following the ingestion of food. Fatalities result from severe laryngeal edema, irreversible bronchospasm, refractory hypotension, or a combination thereof. Peanuts, tree nuts, fish, shellfish are the foods most often implicated in severe food-induced anaphylactic reactions, although anaphylactic reactions to a wide variety of foods have been reported. Fatalities caused by reactions to milk have increasingly been noted. So that's it for the food allergy. So that's all of it for the medicamentosa dermatitis and the food allergy. So I hope you've enjoyed while watching and listening to my video. So that's all. Goodbye and keep safe, everybody.